Alright guys, can you all hear me? Can you all see me? Quick feedback. Quick feedback. What happened? It's live. Yeah. Alright guys, can you all see me? Can you all hear me? Can we start? Can we start? Good evening, Tani. Good afternoon. Okay, so let's kickstart the discussion. Yeah, okay. Guys, the PDF of the session will be available or made available to you. There's a group that I run for normal students and all where I interact. It's on a Telegram. I'll ask the admin to share the group across with you. You'll be able to get the PDF down across there. Okay. Already there's an old PDF, there's a new PDF, there's a current PDF, bahut PDF, and you have all the notes also. You can access it through there. There's no issues at all. Okay. Chalo. So can we start? Can we start? Can we start? Can we start? Chalo. So again, a very important topic from the exam perspective, that is thyroid swellings. We'll start. Yeah. So everything will be available, guys. Everything will be available. Let's not waste any further time. Let's kickstart. Right. Once the session is done, I will have a little bit of time to interact with you guys. I'll answer all your queries back then. Right. Chalo. So in an inflammatory thyroid swellings, we have three important swellings. We have Hashimotos, de Quervain's, and Reeder's thyroiditis. Type of inflammation: Hashimotos is an example of chronic inflammation. De Quervain is an example of subacute inflammation. Reeder's is an example of chronic inflammation. Reeder's is an example of chronic inflammation. Hashimoto's, it is autoimmune in nature. It is autoimmune in nature. De Quervain's, it is basically post-viral upper respiratory tract infection. Reeder's, it is idiopathic. Majority of them is idiopathic. If not, then autoimmune. AI stands for autoimmune. It could be autoimmune as well. In Hashimoto's thyroiditis, as it is an autoimmune disorder, it is, when we talk about pathophysiology, there is an antibody that is developed. No? The antibody in Hashimoto's is your anti-TPO antibody. There is no antibody here, but if it is Reeder's associated with autoimmune, it is your IgG4 class of antibody that is usually developed across here. Now what happens is this anti-TPO antibody which is present, no, you need to understand, if this is the antibody that is present, right, this is your anti-TPO antibody that is formed. Now this antibody, it decides to go and kill the thyroperoxidase enzyme which is present inside the thyroid follicle. Now if you take this as a representation of thyroid follicle, and let's say this is the thyroperoxidase enzyme, the TPO is inside the follicular cell. So these antibodies go to the follicles and they tell that follicles to pull or bring the TPO out. I want to kill. Follicles is get lost here. If I give you TPO, how will I survive? Because everything that happens inside the follicle is taken care of, governed by the TPO only. So I cannot give you thyroperoxidase. These antibodies, they feel very sad. They get very angry because they want to kill TPO. Follicle is not allowing, but they are not strong enough to kill the follicle. So when you are not strong enough to kill somebody, what will you do? Go buy or hire an assassin. Same way, this antibodies go to the best assassin in the body, that is CD4 cells. They activated CD4. Bolta, yaar, it's such a small job. I can send my best assassin, that is CD8 cells, which is cytotoxic. Problem with CD8 cells, no, they don't talk. They directly go and photophy, they just go and just kill it. So this CD8 cell goes without talking to follicle. Follicle is trying to explain, it just get lost, and then it disrupts this, right? And this disruption will cause two problems. One, it will release the thyroperoxidase enzyme, so TPO is being released out. So you will see the TPOs release, these antibodies will take care. But more importantly, you will also notice that we had this T3, T4 hormone, which is in a reserve state. It will also cause excessive release of T3, T4, resulting in toxic state as well, right? And these antibodies which are present here, these antibodies will go and bind to this thyroid peroxidase enzyme, and they say their revenge is completed, right? And the thing has been done, right? So this is with respect to the Hashimoto's thyroiditis. D. Corbin's thyroiditis, it is a cross-reacting antigen, right? So basically what happens in post-viral upper respiratory tract infection, the antibodies which are formed, they recognize follicles as antigen. Now, because they recognize follicle as antigen, they will cause inflammation of the follicles. And this inflammation of follicles is what we call it as the D. Corbin thyroiditis. Riddles, it is idiopathic. We don't know what happens. Let's say if I give you this as a representation of the thyroid gland, and let's say these are the follicles which are present across here, right? Let's say these are the thyroid follicles which are present. We don't know why or how, but I can give you a small analogy. Let's say, one day the thyroid gland was thinking about its future, and I was thinking how life is gonna be, how it's gonna be difficult, how it's gonna deal with all this, like all this moh maya and all. He gets very irritated. So thyroid follicle bolte hai, do enough, fought enough in life, I don't want to do anything, I have decided to quit. And the minute it decides to quit, what is going to happen? These follicles who are quitting, they will die, they commit suicide. The problem is, the guys who commit suicide is not the issue. The guys who are left behind, they have to bear all these problems or the loss that they have to bear. In the same way as the follicles, these follicles have died. They don't have any problem, they're dead. But the follicles which are left behind, because they have died, they have to share their load of work and the burden to compensate for their loss. They undergo hypertrophy so that they can be able to produce the same amount of hormone without causing any trouble to the body, and this is your compensatory hypertrophy. So in Riedels, a few of the follicles get fibrosed, autofibrosis, and the other ones cause compensatory hypertrophy. Now, again, few other follicles, they are going to get depressed, they are going to get damaged. In that way, eventually you will notice all the follicles in the thyroid gland, in the Riedels thyroiditis, they undergo fibrosis. In fact, the entire gland becomes enlarged, fibrosed thyroid gland. Why enlarged? Because of compensatory hypertrophy. Why fibrosed? Because it is autofibrosis, right? So this is how it has been depicted across, right? So in Riedels, what is the scenario? So Hashimoto's, it is autoimmune. D. Corbin's, it is cross-reacting antigen-antibody complexes. Riedels, it is because of idiopathic autofibrosis. Now, is there an HLA association? Remember, same as Graves, it is HLA B8, HLA DR3 and HLA DR5. Whereas in your D. Corbin's, it is HLA B35. There is no specific HLA with respect to Riedels thyroiditis. Now, Hashimoto's thyroiditis is seen between 20 to 30 years in relatively younger patients. D. Corbin is seen between 30 to 40 years. Riedels is seen after the age of 50 years. All these disorders are more common in females when compared to males, right? In Hashimoto's, the patient will have presence of thyroid swelling and associated symptoms. Now, majority of them, thyroid swellings, along with the thyroid swellings, they will also have signs and symptoms of hypothyroidism. Here, the patient will complain about pain in the midline of the neck. Another very important component, the pain increases during swallowing, because during swallowing the gland has to move, and an inflamed gland, when they are disturbed, they will cause more amount of pain, and there will be, may or may not be associated with thyroid swelling. Now, swelling here is because of inflammation. Here, patient will have a huge thyroid swelling. There will be a huge thyroid swelling. along with huge thyroid swelling, there will be signs and symptoms of hypothyroidism. There is signs and symptoms of hypothyroidism. Along with that, it will also have a very important aspect that is going to be the pressure symptoms. Why pressure symptoms? As the gland enlarges, it is going to compress. It is going to compress the trachea, the esophagus, and the rectolaryngel nerve, resulting in pressure symptoms, severe pressure symptoms. When we talk about initial thyroid status, as soon as the follicle ruptures, in Hashimotos, you will see hyper. There is no intermediate, but once the gland fibroses, they will become hypo. In decurvence, excessive irritation of follicles will cause more amount of thyroid release. So initially it is more. Once the inflammation subsides, the follicle will start to build their reserves. So intermediately there will be hypo, but eventually they will become euthyroid. Riddles vena from day one only, because they're getting damaged, it is going to be hypothyroid in status. Now for the investigation, obviously I will be performing the thyroid function test with fmge with antibody titer. Here I would do a thyroid function test with ultrasound is more than enough. Here I would do a thyroid function test with fmge and with antibody titer, that is your IgG for class of antibodies, right? Management, it is going to be thyroxine for lifelong. It is going to be thyroxine for lifelong. It is self-limiting, so in decurvence I don't need to do anything, because you can see it is becoming euthyroid by itself, right? Whereas Hashimoto's, I have to give thyroxine for lifelong. We have to give thyroxine for life, but if there is severe pressure symptoms, and then you have to do isthemectomy. In fact, isthemectomy is the surgery of choice to relieve pressure symptoms in an inoperable thyroid state. Is that okay? Right? So, in a nutshell, this is what you have to remember about the the thyroid swellings per se, which are inflammatory in nature. Is that clear? Very important table. This will yield at least a question if they want to ask it from thyroid. Is that okay? Chalo. Moving on, again a very important topic, that is going to be thyroid carcinoma, right? Now, there are 4 standard varieties of thyroid cancer. We have the papillary, we have the follicular, the anaplastic, and the medullary cancer thyroid, right? Now, when you talk about the origin of these, remember papillary is follicular in origin. Follicular, obviously it is follicular in origin. Anaplastic is also going to be follicular in origin, whereas medullary is going to arise from parafollicular C cells. It is your parafollicular C cells, right? Now, when you talk about the most common thyroid cancer, that is going to be papillary cancer thyroid. Now, papillary cancer thyroid can be seen at any age, but it is usually in 30 to 40. Follicular is between 40 to 50 years. Anaplastic is beyond 50 years. Medullary cancer thyroid, if it is sporadic, that means associated with general population, it is seen after the age of 60 years. If it is associated with multiple endocrine neoplasia, around 20 years, it is noticed, right? So age depends upon whether it is sporadic or associated with multiple endocrine neoplasia. All these disorders or malignancies are more common in female when compared to male. They are more common in female when compared to male. Now, the genes which are responsible, remember the most important for this is BRAF. Here it is going to be P10 mutation. There is no specific mutation. Whereas RET mutation is seen with respect to the medullary cancer thyroid, right? The most important risk factor for the papillary cancer thyroid, it is your thyroglossal duct system. Another one is history of radiation exposure and the history of radiation exposure. It is the history of radiation exposure, right? On the other hand, when you talk about in terms of the follicular cancer thyroid, it is long standing, goiter is an important risk factor. Okay. There is no specific risk factors for these two. These are the two important risk factors that we have spoken across, right? For papillary cancer thyroid, they will present to you as solitary thyroid nodule-like presentation. They present to you as solitary thyroid nodule. Follicular cancer is going to present to you as, it is going to be as goiter-like presentation. It is going to be goiter-like presentation. Anaplastic is the most aggressive form. So here you will see there is huge thyroid swelling. There is huge thyroid swelling, but along with huge thyroid swelling, it is also associated with severe pressure symptoms. It is associated with severe pressure symptoms. Medullary cancer is going to present to you as solitary thyroid nodule. As solitary thyroid nodule. But along with the solitary thyroid nodule-like presentation, it is also associated with diarrhea. Diarrhea is because of excessive production of 5-HT3, which is called as serotonin. If it is associated with Men's syndrome, then pheochromocytoma. In a pheochromocytoma, they will have headache and hypertension. They will have headache and hypertension that is seen across here, right? So these are, one second. Okay. So these are with respect to the clinical presentation. Now, when you talk about the mode of spread, remember for papillary cancer thyroid, it is lymphatics. For follicular, it is hematogenous. For anaplastic, it spreads directly. And here it is going to be both lymphatics and hematogenous. It is going to be both lymphatics as well as hematogenous. The most common site for secondary or metastasis. The most common site for metastasis with respect to papillary cancer thyroid, it is going to be the lungs. Here it is going to be flat bones, that is in the follicular. Again, direct here it is lungs. In medullary it is liver. If not, then it is bones. Now remember, whenever we talk about bones, type of secondaries are important. In follicular it is osteolytic secondaries. Here it is osteoblastic secondaries. Now if you have a doubt, follicular, does it have lytic, or medullary if it is having blastic? In simple mnemonic, Sachin Tendulkar, master blaster, master means medullary, blaster means blastic. So medullary will have blastic cancer. Okay? So that is what you have to remember with respect to this. Now, when it comes down to investigation, for investigation thyroid function test, we have to do an FNSC. TFT, FNSC and ultrasound of the neck. These are the standard investigations that you're going to do, right? Now the problem is when you do FNSC of the follicular cancer thyroid, remember your pathologist will tell you that they cannot differentiate between follicular adenoma and follicular carcinoma. So whenever you do FNSC, your pathologist will tell you it is a follicular origin. But the problem is, in a follicular origin, we have the follicular adenoma as well as follicular carcinoma as well. So we have both follicular adenoma as well as follicular carcinoma. My question is, how do you differentiate? So what they do is they are going to perform lobectomy, right? So whenever they get the follicular origin, they will perform lobectomy. They will perform lobectomy. So in the lobectomy, we will see the status of follicular adenoma and carcinoma based upon two important aspects. Number one, it is the capsular breach and the vascular breach. In follicular adenoma, there is no capsular or vascular breach. In follicular carcinoma, it is associated with both capsular as well as vascular breach. The only way you can differentiate between a follicular adenoma and a follicular carcinoma is presence and absence of capsular and vascular breach, right? There's nothing specific. Again, same for anaplastic cancer also. For an anaplastic cancer, you would do the same thing, that is the thyroid function test. I would do an FNSE and the USG of the neck. For medullary cancer, I would basically perform only FNSE and the ultrasound of the neck because it is originating from parafollicular C cells, right? So on FNSE, what do you see? Now, these are the characteristic features for your papillary cancer thyroid. You see this empty vacuolated cell that is present and there is no nucleus. This is what we call it as the orphan annii nuclei. It is an orphan annii nuclei, right? On the other hand, when you see this concentric mosaic pattern, no, like a rosette that you are able to see, I hope you are able to identify this rosettes, this one. If you look across here, you see this concentric mosaic rosette like pattern. These are your samoma bodies. These happens to be your samoma bodies, and these samoma bodies are an example of fine dystrophic calcifications. These are fine dystrophic calcifications. These are an example of fine dystrophic calcifications. Now, can you tell me where else do you see samoma bodies? Where else do you see samoma bodies? Anybody? Where else do you see samoma bodies? Quick feedback. Samoma bodies, they're seen in your favorite subject. What is your favorite subject? PSM. What does P stands for? It is the papillary variant of renal cell carcinoma and obviously the papillary variant of thyroid cancer. Another one, it is your serous cyst adenoma of ovaries. It is the serous cyst adenoma of the ovaries, right? And M stands for meningioma. M stands for meningioma, right? So papillary variant, serous adenoma of the ovaries and meningioma are the sites where you will see presence of samoma bodies, right? Now you see these empty cells, you can see they are not stained, no? These cells which are not stained, these are what we call it as oxyphilic cells. Now if the oxyphilic concentration is more, it is defined as the Hurthal cell carcinoma. It is a Hurthal cell carcinoma. It is a variant of follicular cancer thyroid. It is a variant of follicular cancer thyroid. Nothing specific that you see in anaplastic, but here in the medullary cancer thyroid, I hope you are able to see this looks like a muscular band between the cells, no? And this is nothing but your amyloid in stroma. This is the amyloid in stroma presentation, right? All these are exam question with images I've shown you, right? So amyloid, oxyphilic cells, orphan annii nuclei, and the samoma bodies, right? This is max they can ask you with respect to thyroid cancers. Okay. Obviously, the management is total thyroidectomy. Clear? Okay. So this is all the important aspects of thyroid cancer that you should be aware of. Clear, guys? Quick feedback. Any questions, any doubts so far? So far, any questions? Okay, chalo. So we'll be talking about another important topic in terms of revisional status. So another very important topic from the exam perspective, it is the breast surgeries, right? When you talk about simple mastectomy, what do we remove? We remove the entire stroma of the breast. We remove the entire glandular component of the breast. Along with that, I am going to remove the nipple and the areolar complex. If you do this, it is your simple mastectomy. The radical mastectomy is also called as the Halsted's surgery. In an Halsted surgery, I am going to perform simple mastectomy. But along with simple mastectomy, I will remove the pectoralis major muscle. Along with that, I will also remove the pectoralis minor muscle. Along with that, I will remove level 1, level 2 and the level 3 group of lymph nodes. I will remove level 1, level 2 and the level 3 group of lymph nodes will be removed. That is a radical mastectomy. Now the modified radical mastectomy, which is also referred to as the Patty's modified radical mastectomy. Here we will do again a simple mastectomy. Along with simple mastectomy, I am going to remove only the pectoralis fascia, not the muscle. And I will remove level 1, level 2 and the level 3 group of lymph nodes. I will remove the level 1, level 2 and the level 3 group of lymph nodes. Okay. So these are with respect to modified radical mastectomy. Now, as of now, remember, surgery of choice for breast cancer, it is your modified radical mastectomy. It is the surgery of choice for operable breast cancers. It is a surgery of choice for the operable breast cancers, right? So when you talk about the structures that should be preserved during a modified radical mastectomy, they can be remembered by a small mnemonic, that is our ABCD structures. A stands for axillary vein. We have to preserve the axillary vein. B stands for Bell's nerve, that is your long thoracic nerve. It is your long thoracic nerve. C stands for cephalic vein. C, it is your cephalic vein. And D stands for nerve to latissimus dorsi. It is the nerve to latissimus dorsi that has to be preserved, right? So these are the structures that should be preserved in modified radical mastectomy. What are the complications of modified radical mastectomy? They can be remembered by a small mnemonic, that is SWAB. S stands for seroma formation. W stands for winging of scapula. I hope everybody knows the winging of scapula is because of damage to the long thoracic nerve during the surgery. A stands for arm edema, that is upper limb edema. Another one is axillary vein thrombosis. It is the axillary vein thrombosis. It is the axillary vein thrombosis. B stands for black. Black indicates flap necrosis. It indicates flap necrosis. And remember, seroma happens to be the most common post-operative complication. Seroma is the most common post-operative complication, right? So these are important aspects with respect to breast surgeries that you have to remember. Okay? This is more than enough in terms of breast surgeries from your exam perspective. Okay? So now in the vascular surgery, they can ask you two important aspects. One is your Burgess disease, another one is atherosclerosis. Everybody knows it. Burgess is also called as thromboangiitis obliterans, because see, the word is so beautiful, no? Thromboangiitis obliterans. Angiitis is inflammation. Because of that, there is a thrombus, and that thrombus is occluding the blood vessel. Thromboangiitis obliterans, right? Now, when you talk about Burgess, every patient of Burgess will present to you under 40 years. Atherosclerosis is over 50 years, right? The most important risk factor is going to be smoking, whereas atherosclerosis, it is going to be obesity. The most common limb, remember, in Burgess, all four limbs are equally involved. Atherosclerosis, it is the lower limb, which is far more common when compared to involvement of the upper limb. Now in Burgess, the size of the vessel involved, it is small to medium sized blood vessel. Atherosclerosis, it is always large to medium sized blood vessels. It is always large to medium sized blood vessels. What is the pattern of involvement? Remember, in Burgess, it will be skip lesions, right? It is not a continuous lesion, and this skip lesion will be involving the artery, it will be involving the vein, and it is also going to involve the nerve, right? So artery, nerve and vein, all three structures are involved, whereas atherosclerosis, it is going to be in a continuous manner, and that too only artery is involved. It is only the artery it is involved. The progression for Burgess, it is always from the distal end of the vessel to the proximal end of the vessel. So progression is from distal to proximal, that is from lower down towards the heart. Whereas in atherosclerosis, it is always proximal to distal end of the vessel. This is the progression that you will see, right? Now, as I told you, structures involved here, it will be involvement of artery. Here it is the vein that is involved as well as the nerve that is involved. Here it is only the artery that is involved. It is only the artery that is involved. Right? So these are the structures which are involved, right? So Burgess and the atherosclerosis, right? Again, majority of your exam questions about the Burgess and atherosclerosis is only from this table. Now, to assess the severity of the disease, for the severity of the disease, we have an index which is called as Abpi index, that is ankle brachial pressure index, right? It is the ankle brachial pressure index. How do you measure the ankle brachial pressure index? The ankle brachial pressure index is measured by systolic blood pressure at the level of ankle to the systolic blood pressure at the level of the brachial artery. It is the systolic blood pressure at the level of brachial artery. Okay. So when we say the normal Abpi index, it is going to be 1 to 1.3. In a calcified blood vessel, Abpi index is more than 1.3. If it is less than 0.9, it is intermittent claudication. Less than 0.5, it is rest pain. And less than 0.3, it is critical limb ischemia. It is a critical limb ischemia, right? Now, when you have an atherosclerosis, no, in atherosclerosis, you can have occlusion at iliac, and the femoropopliteal occlusion, three sites. So, where the aorta is bifurcating, where the iliac vessels are bifurcating, and between the femoropopliteal junction. Now, obviously, the claudication will be present in all three of them. Aortoiliac will have claudication at the gluteus, thigh, and calf. There is no claudication here, but claudication will be here in thigh and calf. In femoropopliteal, the claudication is only present. The claudication is only present in the calf region. It is going to be calf region, but here claudication will be bilateral. Here in both these conditions, it will be unilateral. It will be unilateral. Now management, here I will do an aortobifemoral bypass. It is your aortobifemoral bypass. Here we will do only the aortofemoral bypass. Here we will perform an aortofemoral bypass, and here we will go a iliopopliteal bypass. Here we will perform an iliopopliteal bypass, right? For this bypass, we will use Dacron graft. For this bypass also, we will use the Dacron graft. Here we will use an autologous, that is same patients in a reversed manner, great Cephalus vein. So autologous reverse great Cephalus vein is going to be used as the product, right? So we're going to use it in terms of bypass, right? So these are all the important aspects with respect to vascular surgery. Now, from the exam perspective, two important questions here. Number one, the Abpi index, and number two is the site of occlusion and management and presentation accordingly. Is that clear? Okay. Chalo. So this is about the arterial disorders that you have to know across. Okay. Now, another important aspect from the exam perspective is going to be about the plastic surgery. Now, in the plastic surgery, usually they will ask you about the skin grafting. So we have two types of skin grafting, the partial thickness and the full thickness. The partial thickness is also called as Thyroid. The full thickness is also called as Wolfie's, right? The device used to take the graft out is called as a Humbee's knife, also called as the electric, or you have another one, the electric dermatome. How do you know that you've taken the correct thickness? So when we say there is a partial thickness skin graft, in a partial thickness skin graft, what are we going to take? In a partial thickness skin graft, I will take the entire epidermis of the skin. Along with that, a part of dermis is taken. Along with that, a part of dermis is taken. In a full thickness, I will take the entire epidermis. Along with that, a full thickness dermis is also taken. A full thickness dermis is also taken, right? So you have this are the components, right? So we have the epidermis and the dermis as the full thickness. Partial thickness only epidermis, and the part of the dermis is taken along with it. How do you know that you've taken the correct thickness? If there is presence of punctate hemorrhage, that means you've taken correct thickness of partial. If the subcutaneous fat is exposed, you've taken full thickness, right? Now, couple of questions about the donor site, right? The defect in a donor site for a partial thickness, it is temporary. It is temporary, right? That means it will heal. Whereas here it is the permanent, right? Scar, there is no scar here. It will leave a scar. Because it is temporary defect, you can take any size of the graft. Here it is only small size are recommended. Repeat grafting can be done from the same donor site. Here it is not possible. The most common site for the graft extraction, it is the lateral part of the thigh. Whereas when it comes down to the other end, that is full thickness, it is behind the ear, that is retroauricular. It is the retroauricular. Now, when I talk about graft survival, the graft survival is good here. The graft survival is poor because both of them require nutrition from the surrounding region. No? So, full thickness will demand more, or whenever the demand is more and the supply is not able to compensate, the graft will give away. Now, graft contracture, here it is more of secondary when compared to primary. Here, more of primary when compared to secondary. That is why it will have poor cosmetic outcome, whereas this is going to have a good cosmetic outcome. Now, those are thinking, sir, what is primary contraction and what is secondary contraction? For them, a quick succession. Whenever you take the graft from the donor site, it contracts immediate. That immediate contraction is primary. After you apply the graft to the recipient bed, and then when it contracts, it is called a secondary. So whenever this secondary contraction is more, it will have poor cosmetic outcome, right? So because the secondary contraction is dominant in partial thickness, the cosmetic outcome is poor, whereas on the other hand, the cosmetic outcome is better. Okay. Okay. So this is with respect to the same components, right? Guys who are looking for the Telegram group, you have to find it as, I think it is called as General Surgery Ultimate. It is the General Surgery Ultimate. That's it. That's the only name that you'll find. And it's a free group. You can join. You don't need any admin permission or anything. Don't worry about it. There you have this PDF also. If you want, you can extract it from there as well. Okay. So this is with respect to the skin grafting. That is very, very important. Okay. Sure. Now, what are the reasons for the graft failure? There are following reasons. We have hematoma, we have seroma. Hematoma is the most common cause for graft failure. Then you have seroma, repeated movement at the graft site, infection. Remember, in an infection, if there is presence of beta hemolytic streptococci, if there is presence of beta hemolytic streptococci, it is an absolute contraindication for skin grafting. It is an absolute contraindication for skin grafting, and if there is absence of periosteum of the bone. So whenever there's hematoma or seroma, now how do you prevent the collection? By a technique that is called as pie crusting. Now in a pie crusting, you put these small holes on the skin graft so that all these hematoma and seroma can escape out. All the seroma and hematoma can escape out. Clear? So this is with respect to graft failures. Okay. One second, guys. I want to discuss few important points about burns also. I think it should be here. Okay. Now, again, a very important topic from the exam perspective, it is burns. The rule that we use for the assessment, it is called as the Wallace rule, or also called as rule of 9, right? So in the adult, the head and neck comprises of 9%. The anterior trunk is 18%. The posterior trunk is going to be 18%. Anterior is 18, posterior is 18. The upper limb is going to be 9% each. The lower limb is going to be 18% each. The palm accounts for 1% and the perineum accounts for 1%, right? For children, the head and neck is going to be 18%. Rest everything, anterior posterior trunk is same. The lower limb is same. The upper limb is same. The lower limb is 14%. That is what you have to emphasize across. Okay. Now, when you classify the burns based upon the depth, right? I can divide them into first degree, second degree superficial, second degree deep, third and fourth degree. On what? Structures involved. First degree, only epidermis of the skin is involved. Here it is involvement of papillary dermis. Here there is involvement of papillary dermis. Here it is involvement of reticular dermis. In a third degree, it is full thickness of the skin. It is the full thickness of the skin. And in the fourth degree, there is involvement of an underlying structure. There is involvement of underlying structure, right? So these are your fourth degree burns. Remember, first degree burns are extremely painful. Second degree superficial extremely painful. Second degree dip, there is no pain, but there is something called as pin prick sensation. So if you prick it with the pin, the patient will be able to get across here. Okay. The third degree, there is no pain. The fourth degree also, there is no pain at all, right? The blisters may or may not be seen in first degree, but they'll definitely found in second degree. Second deep may or may not. There are no blisters in third and fourth degree. The color in first degree is going to be bright red, or I can say, sorry, as it will present to as erythema. In second degree superficial, it is going to be bright red in color. Second degree deep, it is going to be mottled pink, that is pink with white dots, or the waxy white. Mottled pink or waxy white. Here it is leathery in appearance, and here like a charcoal, it is charred. It is charred. Now all these three will heal. The third degree, fourth degree will never heal. There will be no scar here. The scar will be left. Now the third and the fourth degree cannot heal. So we cannot say the scars are even applicable here, right? When you talk about the presence of eschar, remember eschars are not usually formed here. The eschars will be formed in these two. There will be presence of eschar in these two statuses, right? So this is how you differentiate the various degrees of burns. Okay. Now, in the burn resuscitation, we all know the crystalloid of the choice or the fluid of choice for burn resuscitation. The fluid of choice for burn resuscitation is going to be Ringer lactate. It is going to be Ringer lactate, and we have a Parkland formula for resuscitation, that is 4 ml per kg per percentage of body surface area burn. Now, I want to clear one thing. There's a lot of confusion where the students are thinking, no, the Parkland formula has changed. It has not changed. It is same as 4 ml per kg per percentage of body surface area burnt. It will remain the same. What is there? There's a new addition, that is your Atls formula. Atls says that if there is a second degree or a third degree burn, and if the patient is an adult, then I will use 2 ml per kg per percentage of total body surface area that is burnt. Right? Now, if you have a second degree or a third degree burn, but this time it is a pediatric age group, that is child, then I will take it as 3 ml per kg per percentage of total body surface area that is burn. Right? Next, if there is a fourth degree burn, or if it is an electric burn, irrespective of the age, we will take it as 4 ml per kg per percentage of total body surface area that is burnt. Right? So second degree, third degree, adult is 2, child is 3, electrical burn of 4th degree, it is going to be 4. Right? So this is on the basis of ATLS, right? Again, please do not confuse. Parkland is different. ATLS is going to be different. Now, when it comes down to the fluid administration, right? How do you administer fluid? Now, for the fluid administration, again, a lot of confusion. People will think, sir, how do you calculate? What do you do? I'll give you a simple example, right? We'll take it Parkland only. Let's say I have a 70 kilogram patient with 30% of total body surface area that is burnt. So according to Parkland, is 4 ml per kg per percentage of total body surface area burnt. It will come down to as 8,400 ml, right? I'm super fast at math, right? Or else I've already remembered this example. You can see it either ways. Now, once you've calculated this 8,400 ml, this 8,400 ml is the ringer lactate that I have to give, and this has to be given within 24 hours. This has to be given within 24 hours. So what I'll do is I will divide them into two equal halves. That is 4,200 ml and 4,200 ml. Now the first 4,200 ml, I am going to give it as fast IV within 8 hours. Within 8 hours. Whereas the next 4,000, I will give it as slow IV, that is within 16 hours. But in total, that is within 24 hours, I have to finish the entire burn fluid. Now, majority of the students have asked me, sir, after 24 hours, what will you do? But after 24 hours, I am going to keep the patient on maintenance fluid. Now, you will say, sir, how do you calculate this maintenance fluid? देखिए maintenance fluid के लिए we have a standard rule that is called as 4-2-1 rule. Now, what does it mean? I have a patient who's 70 kilograms. No, for this 70 kilograms, I can write the first 10 kilograms, the second 10 kilograms, rest of the body weight, that is 50. So total it is 70 kilograms, right? So I can write first 10, second 10, and the rest of the body weight, that is 50 kilograms. Now we say for the first 10 kilograms, we'll give 4 ml per kg. For the next 10 kilograms, I will give 2 ml per kg. For rest of the body weight, I will give 1 ml per kg. So 4 ml per kg becomes 40 ml. 2 ml per kg here becomes 20 ml. Rest of the body weight 1 ml per kg will become 50 ml, right? So when you add all this, it will become 110 ml, and this is given per hour. So this is how you will calculate your maintenance fluid, right? This is how you're going to calculate your maintenance fluid, that is 110 ml per hour. Clear? Is that clear, guys? Okay. So these are the concepts in burns that you should be aware of. Clear? Clear? Quick feedback. So far, any questions? Any doubts? Quick feedback, quick feedback. So do not confuse between Parklands and ATLS, right? That is the carry-home message that you need to take across. Okay. Sure. Now we'll talk about the systemic part in the GIT. That is going to be absolutely important. The first one that we have is your okay, rather than using this annotations, I'll be taking across on this session. Okay. So quickly looking at the GIT part, can we start? Okay. So in the GIT, one of the most important aspects is going to be your esophagus, right? So in the esophagus, we'll talk about the congenital disorders. That is your congenital, that is tracheoesophageal fistula. We have the tracheoesophageal fistula. So talking about the tracheoesophageal fistula. Okay. Now, when you talk about the tracheoesophageal fistula, it's an abnormal communication between the trachea and the esophagus. We all understand this. There are different types. I hope everybody knows across it. Now, if you take this as the representation of the trachea, how the esophagus behaves along with the trachea, we have different varieties. So I'll just quickly draw for you. Let's say these are the tracheal orientations that are present. Now, in the type 1 variety, you will see the esophagus is having an atresia. There is no fistula that is present, and the stomach continues across. This is your type 1 variety. In the type 2 variety, you will notice the upper segment is communicating with the esophagus, whereas the lower segment is having an atresia, and this continues across. This is your type 2 variety. In a type 3 variety, you will see it is the lower segment that is communicating. The upper segment is maintaining an atresia. So this is atresia here. The lower segment communicates across here in this manner, right? This is your type 3 variety. Now, I hope everybody knows the type 4 variety also. Type 4 variety is going to be a combination of these two. So in the type 4 variety, you will see there are two communicating segments, the upper fistula and the lower fistula. Right, so both upper and the lower segment communicating, it is the type 4 variety, and the last one is the type 5 variety. So in a type 5 variety, basically there is no atresia per se. There is no atresia per se, but you will notice that there will be an existent fistula. So the esophagus is going to communicate in this manner, and this is what we call it as a type 5 variety, is also referred to as H type. It is also called as the H type. Now my question to you is, which among the following is most commonly clinically presenting, right? I hope everybody knows it is a type 3, which is the most common type clinically, or you can say the lower segment fistula. The lower segment esophageal fistula is the most common presentation. This is the most common presentation, right? Now, how does a patient present to you? I hope everybody knows it in terms of clinical presentation. Quickly looking across it. Now, I'll be talking about the clinical presentation of the type 3 variety. Now, in a type 3 variety, as we just discussed, it is the upper atresia and lower fistula. So, this is the trachea that is present here. You will notice the atresia is maintained on the upper segment, and then you will see that the lower communicating part is going to be communicating with the fistula right across it. So what is the complaint the mother is going to come to us? See, the initial complaint of the mother, every time the baby is fed any feed, let's say the milk is being put, what is going to happen? The milk is going to enter. It is going to enter into the esophagus in an atresal segment. It cannot stay any further. So it reverts back, right? So mother's complaint would be repeated regurgitation. There is repeated regurgitation of all feeds. When I say all feeds, that means every time the baby is fed, there will be regurgitation. Now, along with regurgitation, as babies produce more amount of saliva, in a normal baby, the saliva would have gone into the esophagus, stomach and disappear. but here you will see the saliva will continuously pool. Now, as there is continuous pooling of saliva and the esophagus is going to fill up, obviously the saliva will also drool continuously. Another finding that you will see, there is continuous drooling of saliva. So there is repeated regurgitation of all feeds. There is continuous drooling of saliva, and more importantly, every time the baby is going to breathe or cry, what is going to happen? The air which is present here will enter into the trachea. Obviously, it will go into the lungs, but at the same time, some amount of air will go into the fistula. From there, it will come into the stomach and then get trapped. And because of trapping, there will be abdominal distension. So there will be abdominal distension is also noticed. There is abdominal distension. It is also noticed at the same time. Now, every time the baby is fed, there is a regurgitation. During the regurgitation, obviously it is going to come out, but sometimes it can go and spill into the trachea as well. Now, as it spills into the trachea, it will cause irritation. So there will be coughing and cyanosis during feeding. And more importantly, because of this, it can also present you as aspirational pneumonia. It can also present you with aspirational pneumonia, right? Now, you have repeated regurgitation of all feeds, continuous drooling of saliva, there's abdominal distension, coughing, cyanosis during feeding, aspirational pneumonia. All these are life threatening, right? So when you're thinking in terms of this, the investigation of choice, now we prefer a red rubber catheter incision with x-ray. If this is not in the exam as an option, then you can put a nasogastric tube with x-ray can be taken, and the finding, as everybody knows, there will be coiling of nasogastric tube. There is coiling of the nasogastric tube that will be put across here. Okay, so this is the most important aspect, right? So the red rubber catheter with an x-ray. If it is not there, then you have to go with the nasogastric tube. Now, the management, it depends upon where the exact segment is. Now, we have the long distance and the short distance atresia. We have the short distance atresia and a long distance atresia. A short distance and a long distance atresia is noticed. Now, when I say short distance, that means when you see this is the atresial segment. Now, once the fistula is there, if we excise the fistula, let's say this is the trachea that is present. And let's say this was the atresia, fistula that was communicating along with this, right? Now, let's imagine, I'll make it simple for us. Let's say if the fistula was here at this point. Now, the minute we excise the fistula, I'm going to put a ligature here, and then I am going to go ahead and excise the fistula here. Now, once I excise this part, this is the part of the esophagus that is present. I am going to mobilize this part of the esophagus to this end. Now, because it is easily mobilizable, right? As it is easily mobilizable, I am going to make a primary anastomosis. I'll just create a primary anastomosis with these two segments and be done with it, right? So this part will be removed, right? So we have mobilized this segment from the lower part, and then we have anastomosed it, and it is taken care of, right? So I don't need to worry about this is if there is a short distance atresia. Now, if there is a long distance atresia, that means that the primary closure cannot be done because of tension. Now, if you do a tension closure, that means if you close it and they are putting in under tension, if the baby's neck extends, this gives away. If this gives away, it just goes out, right? So you need to be absolutely careful with that. So if, let's say, there is an atresial segment which is maintained here, and the fistula is somewhere down across here, right? And let's say we maintain across. Now, same thing, we are going to ligate it across. Now, once you ligate and once you remove this segment, right, so you have this part that is present. Now, when you try to mobilize this segment, once it has been mobilized, it will probably get oriented like this, right? Now, once it is going to get oriented from this segment to this, the distance between these two, if it is more than 2 vertebral body or more than 2 vertebral distance on an X-ray, we call it as a long distance atresia. Here I cannot do a primary closure. So initially I would do a fistulectomy with feeding jejunostomy. And I will leave it for next 6 months. After 6 months, if the length is adequate, we'll go with primary anastomosis. If it is inadequate, if there is an adequate length, then we will go with primary anastomosis. If the length is inadequate, if there is an inadequate length, then I will take a interposition surgery. I will use a different loop or the conduit. I can use jejunum as a loop. I can use stomach to mobilize, and I can also use colon, which is usually the left colon preferred over right colon. Now the question is, out of these three, which is most commonly used in children? Most common conduit used for interposition in children. Quick feedback. Quick feedback. Quick feedback. So the most common in children is jejunum. Most common in adult, it is going to be stomach. Overall best, it is going to be colon. Yeah. Sure. So this is again a very, very important topic from the exam perspective, right? Another important topic from the esophagus is the motility disorder. In the motility disorder, I'll be talking about the Atresia cardia and the diffuse esophageal spasm. So I'll be comparing these two disorders, that is Atresia cardia and the diffuse esophageal spasm. You have the Atresia cardia and the diffuse esophageal spasm. Now, when we say Atresia cardia, what is the cause? It is mostly idiopathic, or sometimes it can be because of Trypanosomas crucis infestation. Diffuse esophageal spasm also, it is usually idiopathic, or it can be because or secondary to a connective tissue disorder, like example like sclerodermas, right? So they are usually associated with diffuse esophageal spasm. Now, when you talk about both these disorders, when you talk about where do you usually see? The most common site in an esophagus for Atresia cardia, it is the lower 1/3 of the esophagus. Whereas diffuse esophageal spasm is through the entire length of the esophagus. It is through the entire length of the esophagus. Now, one of the most important aspects that you will see with respect to both Atresia cardia as well as diffuse esophageal spasm is their clinical presentation, right? So both of them are going to present to you with dysphagia. Now remember, there is a standard questionnaire, or we call it as the determining questionnaire for dysphagia, no matter which condition do you see. Now remember, here is the concept. Any patient who comes to you with dysphagia, you will ask him 3 questions. Question number 1, is the dysphagia for liquids, or is it for solids, or is it for both solids and liquids? Question number 2, is dysphagia more for liquids or more for solids? Third important question, whether it is a progressive dysphagia or whether it is a non-progressive dysphagia, right? So whether it is a progressive or a non-progressive dysphagia. Now remember, in achalasia cardia, you will see dysphagia for both solids and liquids. Dysphagia will be more for liquids when compared to solids, and this will be a progressive dysphagia. In diffuse esophageal spasm, again dysphagia will be for both solids and liquids. Dysphagia will be equal for both solids and liquids, and this will be a non-progressive dysphagia. Right? So because motility disorders में dysphagia is a presenting feature, it is going to have a presenting feature that is going to be seen across here. Right? Now, when it comes down to achalasia cardia, in an achalasia cardia, if I say what is the most characteristic feature, the most characteristic feature in an achalasia cardia, it is going to be dysphagia more for liquids. It is dysphagia which is more for liquids when compared to solids. This is the only disorder where dysphagia is more for liquids when compared to solids. Along with that, patient will have aspiration pneumonia. Now, aspiration pneumonia is a forte of achalasia cardia. Diffuse esophageal spasm will have severe chest pain. Now, because they have severe chest pain secondary to spasm, this is also described as esophageal angina. This is also described as esophageal angina. Also described as the esophageal angina, right? Now, another important thing is about their barium swallow findings. So, when you take the patient for barium swallow, what are the findings that you will see? For achalasia cardia, number 1, there will be presence of bird beak sign. Number 2, there will be presence of pencil tip appearance. And number 3, there is presence of rat tail appearance. Whereas when you do barium swallow here, it will be presence of cork screw appearance. There will be rosary bed appearance. There will be presence of pseudo diverticulum. There is presence of pseudo diverticulum and beaded appearance. There will be beaded appearance that you see. For both these conditions, the investigation of choice. For both these conditions, the investigation of choice, it is going to be manometry. Here also it is going to be manometry. Right? When it comes down to management, here we can go with surgery, that is your Heller's myotomy. Whereas here, initially you can go with calcium channel blockers or nitrates, but eventually you have to go with surgery, that is long esophageal myotomy. Right? So again, this table is also absolutely important from the exam perspective between the achalasia cardia and the diffuse esophageal spasm. Okay? Clear, guys? So this is between the achalasia cardia and the diffuse esophageal spasm. So for any questions, quick feedback. So far, any questions, quick feedback? Can we move on? Can we move on? Okay. Now, another important aspect is going to be your CHPS, your congenital hypertrophic pyloric stenosis. CHPS is going to be congenital hypertrophic pyloric stenosis. Now the name itself is self-explanatory. Now you can say congenital, that is since birth, hypertrophy. So when I say congenital, that means this is present since birth. Hypertrophy is increase in size of what? Of circular muscles. It is increase in size of the circular muscles in the pyloric region. And that increase in size of circular muscles in the pyloric region, it is causing narrowing of the passage, which is resulting in gastric outlet obstruction. As simple as that, right? IHPS or CHPS are same. That is infantile or congenital, right? So this is congenital hypertrophic pyloric stenosis, right? Now, a couple of important questions. It is commonly found in male babies when compared to females. In fact, it is more common in first born male child. It is more common in a first born male child, right? Usual age of presentation is between 3 to 6 weeks, and the most common age of presentation is going to be 4th week. The most common age of presentation, it is going to be the 4th week of presentation, right? Now, how would a baby present to you in terms of clinical presentation? Let's see. Now, if you take this as a representation of the esophagus, this happens to be the stomach. This is the pyloric part and the duodenum that is present across it, right? Now, you notice that there is hypertrophy of the circular muscles in the pyloric region, right? So this is the pyloric region, and you see there is hypertrophy of the circular muscles. There is hypertrophy of the circular muscles that you are seeing at this particular region. Now, because there is hypertrophy of the circular muscles in this particular region, as the age of the baby is increasing, you will notice this narrowing will become more and more significant, and one fine day it will become so narrow that nothing will be able to move forward. Only a very little content will be able to move forward, and rest of the content will be pushed back, right? So this baby will present with following presentations. So mother's complaint would be this baby is going to present with repeated episodes of vomiting. It is going to be the repeated episodes of vomiting because it is resulting in gastric outlet obstruction. It is not allowing the milk to move forward in any particular direction, right? Now, when you talk about the repeated episodes of vomiting, obviously the mother will take the kid to a pediatrician, right, or to a neonatologist because they're obsessed. No, they want to get it noted, and the pediatricians are also obsessed with vomiting a bit. So the minute they go, the first thing that they'll ask you is what is the type of the vomiting. Now, why I'm asking you is because the bile duct that is present, which travels behind and opens onto the second part of the duodenum, so bile will be present here. Now, when the vomitus is going to be there, it is not going to be bile mixed. So this is going to be non-bilious. It is going to be non-bilious. Remember, whenever there is a proximal obstruction, it will be associated with projectile vomiting. It will be a non-bilious and it will be a projectile vomiting, right? So there will be repeated episode of vomiting which is non-bilious in nature and projectile because it is a proximal obstruction, right? When you look at the abdomen, two things you will notice. You will see as the baby is crying extensively, right? Now, because of that extensive cry, obviously there'll be this contraction where you see the stomach is being filled up with the milk. As the milk comes across, the milk is going to be filled up initially. The stomach will distend, and this distension of the stomach is what we call it as olive lump. Now, this happens once you ask the mother to feed the baby. Now, once you see this olive lump, in this olive lump, there is presence of visible peristalsis. Now, the visible peristalsis, because this is the stomach and it's trying to pump the milk into the forward direction, and you will see that peristalsis that is moving. So the question is, what is the direction of this peristalsis? Left to right or right to left? You will see the peristalsis is from left to right. Now, because if you see right to left, it is colonic peristalsis. Because the orientation of stomach is on the left and it is moving the content forward. No, so left to right will be stomach, right to left will be your colonic peristalsis, right? So there is non-bilious projectile vomiting, presence of olive lump, this presence of visible peristalsis as well, and that is the initial presentation of CHPS. Now the investigation of CHPS is going to be an ultrasound of the abdomen, and the USG you will see presence of double track sign. Now in the double track sign, you see both the circular muscles are hypertrophied on both ends. You will notice that this is one end of the circular muscle which is hypertrophied, and you will notice that this is the other end of the circular muscle that is hypertrophied. So that is why it looks like two tracks of train, so double track appearance. Now the criteria says that the thickness of this tract should be a minimum of 14 millimeters, and the length of this tract should be a minimum of 16 millimeters to make a conclusive diagnosis of CHPS. Now, once you have made the diagnosis of CHPS, the management is going to be laparoscopic Ramsted's pyloromyotomy. It is your Ramsted's pyloromyotomy. So, in the Ramsted's pyloromyotomy, I am going to open from the external surface. So, this is where I will put the incision, right? I will open up the serosa. I will go deep into the, see, as you open serosa, then what do you have? The longitudinal muscles, and then I'll open the circular muscles and I'll allow the mucosa to bulge out, right? So I will deepen the incision till the till the circular muscles are divided, allowing the submucosa to expand. Hence, this is what we call it as Ramsted's pyloromyotomy. Yeah. This is what we call it as Ramsted's pyloromyotomy. All right. Any questions? Quick feedback. Quick feedback. Quick feedback. Okay. So this is all you should know in the context of CHPS. Now, guys, just give me 1 second. I'm getting a constant call from the hospital. Just hold on for a second. Alright guys, let's continue. So this was about the CHPS. Okay. Okay, so another important topic, which is again considered to be very determining one, that is going to be your peptic ulcer disease. Now, in terms of peptic ulcer disease, couple of important things. अगर आपसे पूछा जाएगा, or if they ask you what is the most common site for peptic ulcer disease, what will be your answer, guys? Most common site for peptic ulcer disease. Most common site for peptic ulcer disease. Anybody? Most common site for peptic ulcer disease. Okay, the answer is first part of the duodenum, right? Now, if they ask you what is the most common site for peptic ulcer disease in stomach, if they ask you in stomach, then it is going to be, anybody? It is the angularis incisura, and this angularis incisura, it is present on the lesser curvature of the stomach. On the lesser curvature of stomach. It is going to be the angularis incisura of the lesser curvature of the stomach, right? So the most common site is going for peptic ulcer disease is the first part of the duodenum. Most common site for peptic ulcer disease in stomach, it is going to be the angularis incisura of the stomach person, right? Now, what I'll do is I will take a comparison between the gastric ulcer and the duodenal ulcer. Right? So take the comparison between the gastric ulcer and the duodenal ulcer and see across. Now, when you talk about the gastric ulcers and the duodenal ulcers, as I told you, the most common site, this is going to be the lesser curvature of the stomach. And this lesser curvature of the stomach is at angularis incisura. Whereas duodenum, it is going to be the first part of the duodenum. It is going to be the first part of the duodenum. Okay. Now, when we talk about the peptic ulcer disease, now one of the most characteristic feature, what is the most characteristic feature of peptic ulcer disease? Quick feedback. What is the most characteristic feature of peptic ulcer disease? It is the component of pain. So both of them will be associated with pain. But remember, gastric ulcer, the pain that is present, it is immediate on taking food. It is immediate on taking food. Because the transit of the food from the esophagus to stomach is negligible. You eat, it goes directly into stomach. Whereas the gastric emptying time is 2 to 3 hours. That is why here the pain arises. So here the pain experience or the pain arises after 2 to 3 hours. The pain arises after 2 to 3 hours, right? In fact, the pain in the gastric ulcer, it is severe to moderate in intensity. Here it is mild to moderate in intensity. In duodenal ulcers, it is mild to moderate in intensity. It is your mild to moderate in intensity, right? So this is with respect to the component of pain as well as the presentation. Now, if the pain is going to be there, what will happen to appetite? Now, what is going to happen? Because in gastric ulcer, patient eats, it is attributing to pain. As soon as he eats, he is getting pain. So appetite will significantly fall here, right? Whereas the appetite here, duodenal ulcer, the pain is less severe, and he's after 2 to 3 hours. He's thinking it is hunger pain. So appetite is usually seen more. Now, because there is appetite orientation, I would say in gastric ulcer, patient will have weight loss. Here the patient will have weight gain. Here the patient is going to have weight gain. On top of it, when you look across here with respect to the two important findings, one, that is hemorrhage in a peptic ulcer disease, and second, it can also result in perforation. Remember, it is hemorrhage is more common in gastric ulcer, whereas perforation is more common in duodenal ulcer. The perforation is more common in duodenal ulcer, right? Out of these two, which are associated with H. pylori, H. pylori's association is seen in both duodenal as well as gastric ulcers. It is seen with both duodenal as well as gastric ulcers. Which of them is considered to be as a pre-malignant state? Which of them are considered to be pre-malignant? Gastric ulcers are pre-malignant. Duodenal ulcers are considered to be never pre-malignant. They are considered to be never pre-malignant, right? So these are the important aspects that you will see. Now, if you say what is the investigation of choice for peptic ulcer disease, the investigation of choice for peptic ulcer disease is going to be an upper GI endoscopy. Now, on an upper GI endoscopy, if you see gastric ulcer, biopsy should be taken. For duodenal ulcers, there is no need for biopsy. So, because they are never pre-malignant, there is no inference for biopsy when it comes down to these two aspects, right? So in gastric ulcers, biopsy is a must. In a duodenal ulcer, we don't need biopsy at all, right? So whenever we're talking about in terms of the management for any peptic ulcer, the first line of management is going to be triple therapy. It is going to be triple therapy. Right, so what are the components of triple therapy? Anybody? Components of triple therapy. We'll start the patient on proton pump inhibitors. There has to be antibiotics, right? So you can give amoxicillin or the clarithromycin. Amoxicillin or clarithromycin can be given. Along with that, we are going to give another component, that is going to be metronidazole. Right. So in fact, we give clarithromycin with combination or presence of metronidazole or clarithromycin. Right. So two antibiotics, proton pump inhibitors with amoxicillin or metronidazole, or clarithromycin with metronidazole. Anything is fine. Okay. So this is the triple therapy. Now there is a new therapy. We call it as the quadruple therapy. Now, in a quadruple therapy, same, we will give PPI, we will give amoxicillin or the clarithromycin. Or the clarithromycin with metronidazole, with bismuth or sucralfate. With bismuth or sucralfate can be given. Okay. So these are the objectives as the treatment for peptic ulcer disease. If it is refractory, we'll go with surgery. Okay. So this is with respect to peptic ulcer disease. Very, very important. Okay. Now, what I'll do is to summarize everything in a nutshell, we'll take about few tables which are important from the exam perspective. It will be more like a rapid fire. I'll see if you're able to match up the the questionnaire that we are going to throw at you and see if you're able to come across with it. Okay. So what I'll do is I'll make sections of the list and we'll see accordingly as we go. Right. So the first one is going to be list number 1. In the list number 1, we were talking about named surgeries, right? I will name a surgery. You tell me where it is done. As simple as that. Okay. So let's get focused, right? Let's try to hit it hard and see where we land. Now, number one, Hadfield surgery. Where have you heard about Hadfield surgery? Name surgery. Hadfield, anybody? It is done for duct ectasia. It is done for duct ectasia. Then another one, it is your microdocectomy. Microdocectomy is done. It is the duct ectasia in breast. Okay? It is a duct ectasia of the breast. Microdocectomy, it is the duct papilloma, again of breast, right? Now, you'd have heard about the Halsted surgery. Halsted surgery, we have discussed it. It is your radical mastectomy. It is your radical mastectomy, right? Another one is going to be your Patty's surgery in breast. That is your modified radical mastectomy. That is for modified radical mastectomy. Then you would have heard about Sistrun's operation. So Sistrun's operation is done for thyroglossal duct cyst. It is for thyroglossal duct cyst. Another one, it is the Hartley-Dunhill surgery. It is a variant of subtotal thyroidectomy. It is a variant of subtotal thyroidectomy. So Hartley-Dunhill procedure, what do we do? Now, if you take this as the representation of thyroid gland, this as a representation of thyroid gland, what we do is we remove the entire thyroid lobe of one side, we remove the entire isthmus of one end, and we will leave some amount of gland behind. This is around 10 to 12 grams of the gland is left behind. 10 to 12 grams of the gland is left behind, and this is what we call as the Hartley-Dunhill procedure, right? Now, other procedures that you have done is going to be the Whipple's surgery. Whipple's surgery is also called as pancreatoduodenectomy. Now, the pancreatoduodenectomy is done for periampullary carcinoma. Then you would have thought about the Thierch wiring. Thierch wiring is done for rectal prolapse. Thierch wiring is done for the rectal prolapse. Then you have the Nisbet surgery. That is done for the Perinois disease. It is done for the Perinois disease. Nissen's fundoplication. Nissen's fundoplication, it is done for, guys, where do we do it? It is done for GERD, right? So these are the surgeries that are usually done across here, right? I'll extend the list to 15. Just see if you know. We have the Lord's surgery, and we also have the Jabulois surgery. The Lord's and Jabulois is done for hydrocele. Then you have the Lichtenstein. You have the Shouldes. You have the Bassinis and the Desarda. All these are done for inguinal hernia repair. It is the inguinal hernia repair, right? Another one that you have, it is the Lockwood. It is the Lockwood McEvedy, right? These are done for femoral hernia repair. For the femoral hernia repair. Then you have the Dolman surgery. Dolman surgery is done for the Zenker's diverticulum. It is the Zenker's diverticulum of esophagus. It is the Zenker's diverticulum of esophagus, right? Then you have the Hartmann's surgery. Hartmann's surgery, it is your temporary colostomy. It is a temporary colostomy with rectal stump. It is a temporary colostomy with rectal stump, right? So this is your list number 1. Clear? Now we'll go with the list number 2. Now list number 2, we'll be discussing about the various ulcers. Okay. So I'll tell you the name of the ulcer, you tell me the most common location that you find across, right? Number 1, if you talk about the aphthous ulcer. Aphthous ulcer, it is seen in Behçet's disease. It is also seen in the Crohn's disease. The Behçet's disease and the Crohn's disease. Peptic ulcer disease, the most common site is the first part of the duodenum. For gastric ulcer, it is the angularis incisura of the lesser curvature of stomach. Of the lesser curvature of the stomach. When you talk about duodenal ulcer, that is found on the first part of the duodenum. Then you have Cameroon's ulcer. It is present on the fundus of the stomach, and this is seen in rolling hiatal hernia. It is seen on the rolling hiatal hernia. The Cameroon's ulcer, it is also called as the rider's ulcer. It is also called as the rider's ulcer, right? Then you have the curling ulcer. This is seen in patients of significant burns. Then you have the Cushing ulcer. Cushing ulcer, it is seen in the patient of head injury. Cushing's ulcer is seen in the patient of head injury, right? Where do you see belt-shaped ulcer? Belt-shaped ulcer is seen in anybody. Belt-shaped ulcer, it is seen in, right? It is seen in tubercular ulcer, and we know that tubercular ulcer's most common site, it is going to be terminal ileum, right? Now you have the transverse ulcer in the bowel. Transverse ulcer, it is also seen in tubercular ulcer. Then you have the longitudinal ulcer. The longitudinal ulcer, it is seen in typhoid ulcer. Now in the typhoid ulcer, again the most common site is going to be terminal ileum. It is going to be terminal ileum. Another ulcer which is named, it is the flask shaped ulcer. It is seen in amoebic colitis. And the most common site for an amoebic colitis, it is going to be cecum. If not, then it is ascending colon. The most common site is the cecum. If not, it is going to be the ascending colon, right? So these are the various named ulcers, their locations and causes. Okay? Now, list number 3 is the radiological signs that you will see in GIT. List 3, it is going to be radiological signs. Now, when you look at the radiological sign, we'll tell you about the disorder. You tell me, where do you see? Number one, dysphagia lusoria. In dysphagia lusoria of barium swallow, what do you see? You see either a victory sign or a V sign is noticed. Either a victory sign or a V sign is noticed. Number two, it is the leiomyoma of the esophagus. In leiomyoma of the esophagus, we see a classical teacup sign. We see a classical teacup sign, correct, right? In Atresia cardia, we have already discussed all the signs, but the most characteristic would be bird beak sign. It is going to be bird beak sign. Okay. Then you have diffuse esophageal spasm. We have the corkscrew appearance. We have the corkscrew appearance that is present, right? For esophageal cancer, we have the apple core or long rat tail. Remember, when it comes down to colon cancer, again you would see an apple core appearance. You will see an apple core appearance, right? Now, when you talk about the Crohn's disease, for Crohn's disease, you have the string signs of Cantor. It is the string signs of Cantor, right? Then you have the ulcerative colitis. It is the lead pipe appearance. It is the lead pipe appearance that you have, right? In diverticulosis, what do you have in diverticulosis on a barium enema? You will have a sawtooth sign. There is presence of sawtooth sign, right? What do you have in ischemic colitis? In ischemic colitis, we have the thumbprint sign. In the ischemic colitis, you have some thumbprint sign. In volvulus, you have the coffee bean sign. In intersusception, we have the claw sign. In the intersusception, we have the claw sign that is present, right? In urology, if you talk about it, if you have horseshoe kidney, you have the flower vase appearance. In polycystic kidney disease, there is spider leg appearance. In polycystic kidney disease, there is spider leg appearance. In uretrocele, there is adder head or the cobra head appearance. There is a adder head or a cobra head appearance, right? In TB bladder, number one, it will be addressed as thimble bladder, and there is presence of golf hole ureter. There is golf hole ureter as well, right? So this is with respect to the radiological sign. And the last list is list number 4 for chemotherapies. List 4, we're talking about the chemo regimes of various malignancies, right? We'll talk about the chemo regime of the various malignancies, right? Now, one of the most important malignancies for chemo regime is going to be breast cancer. Now, for breast cancer, the standard regime is going to be the CAF regime. C stands for cyclophosphamide. A stands for adriamycin, and F stands for 5-fluorouracil. It is going to be 5-fluorouracil. Can you tell me for esophageal cancer? For esophageal cancer. Esophageal cancer. What do you have? For esophageal cancer, we have ECF. E stands for epirubicin. C stands for cisplatin. F stands for 5-fluorouracil. F stands for 5-fluorouracil. Carcinoma stomach. Again, we have the ECF regime, that is epirubicin, cisplatin, and 5-fluorouracil. Right? Now for hepatoblastoma. For hepatoblastoma, we have the CVF. C stands for cisplatin. V stands for vincristine. V stands for vincristine, and F stands for 5-fluorouracil. Then you have carcinoma gallbladder. For the carcinoma gallbladder, it is gemcitabine. It is gemcitabine with cisplatin. With cisplatin. Then you have cholangiocarcinoma. For cholangiocarcinoma also, it is gemcitabine with cisplatin. For pancreatic cancer. For pancreatic cancer, it is gemcitabine. It is gemcitabine. For cancer colon, we have Folfox. Now, Fol stands for folinic acid, and Fox, F stands for 5-fluorouracil, and this is oxaliplatin. That is oxaliplatin, right? Then you have anal carcinoma, that too the squamous cell variety. We have the Negro's regime. So when you have the Negro's regime, it is 5-fluorouracil with metamycin C with radiotherapy. 5-fluorouracil with metamycin C with radiotherapy. With radiotherapy. Then you have Wilms tumor. Now with the Wilms tumor, it is CVD. That is cisplatin. You have vincristine and doxorubicin. With doxorubicin. For testicular tumors, for testicular carcinoma, we have B. Bleomycin, etoposide. P stands for platinum compound, that is a cisplatin. That is a cisplatin. Okay. So these are all the important lists for your exams per se. Okay. So this is all that you should know in the context of the entire components of the revision session. Okay. So if you have any questions, feel free to ask. Otherwise, this is what I had in my mind so that I can give you a quick review of all the important exam topics that are to be dealt across. Okay. I hope the session was informative. I try to keep it as much as possible with respect to the presentation and the ease of the exam. Try to cover up the concepts as well, all the previous exam questions as well. I hope this uh, does what it is required for your exam. And from my end, all the best for the exam, guys. If you have any questions, please fire it away. Otherwise, that's it for the today. Thank you so much. People are asking about, I've got a couple of messages for Telegram group. See, the Telegram group is called as the General Surgery Ultimate. There is a link, but how do I give that link? Wait, I'll try to access it in the chat box. Hold on for a second. Alright, guys. I've put the link on the chat box. I hope it is down there. So thank you so much, guys. Have fun. See you guys again. Right. All the best for the exam. Do well. If any questions, keep in touch. Okay. I've sent the link. I don't know why it is not displaying. I'll ask the team to put across the link. Don't worry about it. Right. Sure. Alright, guys. Thank you. Thank you. Have fun. See you. Wait, I'll type the link only, guys. I don't know why it is not getting on. I'll just type it across. It is. All right, so I have put the link there. Okay, sure. Thank you, guys. Have fun. See you. Bye. Guys, there are only two parts. We don't have a third part. Surgery is too vast a subject to cover everything in the speculated time. We try to do the best to our knowledge and try to keep it as crisp as possible. Right? Sure. So signing off, guys. Thank you. Keep in touch. Thank you. Bye.